I would like to thank the Canadian Lymphedema Framework for inviting me to speak on screening for breast cancer-related lymphedema and evidence for early intervention. These are my disclosures. Historically, we have treated lymphedema based on an impairment-based model of care, where the patient presents to us with moderate to severe symptoms and signs of swelling. We have evolved to a more evidence-based, screening-based model of care where we are looking for arm volume changes and symptoms after breast cancer treatment so that we can pick up these changes early and have the opportunity to intervene and limit progression of lymphedema. We know that screening for lymphedema improves diagnostic accuracy, it improves clinical outcomes, patient quality of life, and it is cost beneficial. It is what we should be doing for patients. It is a recommendation of several national and international organizations for lymphedema. And from our data, we know that we should be integrating data including symptoms, objective measurement, clinical examination, as well as we should be empowering the patient to self-screen in between clinic screening visits to report any changes to us so that we have the opportunity to intervene. We've screened over 6,000 women in the Mass General Lymphedema Screening Program. We see patients preoperatively for an arm volume measurement. We then see them postoperatively and at every oncology follow-up visit. We measure arm volume, we collect symptoms data, clinical exam, and we educate patients to self-screen and be vigilant for any changes, reach out to us so that we have the opportunity to remeasure and reevaluate between clinic visits as needed. We follow up every 6 months for a minimum of 4 to 5 years as able. We know we should screen for a long period of time after breast cancer surgery. This represents data from 2,171 women, and we looked at timing of lymphedema based on breast cancer treatment characteristics. And what we found is that patients who underwent lymph node dissection had their highest risk of developing lymphedema between 6 and 12 months post-surgery, so quite early, versus patients who underwent lymph node biopsy had their highest risk of developing lymphedema at 36 to 48 months post-surgery, so quite late. So we really need to be following patients longitudinally over time. Currently, our median follow-up is 31.6 months at MGH. We know that preoperative baseline measurement is imperative. This histogram illustrates data from 1,028 patients that we published, and we found that 28.3% of patients had a preoperative arm asymmetry of 5% or more, and 2.9% of our patients actually had a preoperative arm asymmetry of 10% or more. So if we don't know this, if we don't have this knowledge when we're diagnosing patients and we're diagnosing based on right versus left arm volume asymmetry, this is likely inherently flawed and it is not an accurate way to diagnose lymphedema. So we tried to see if we could use a postoperative measurement as a sort of pseudo baseline, knowing that most screening programs don't have a true pre-op baseline. And we found that the sensitivity of doing this was poor. And in fact, 40 to 50% of patients are misdiagnosed when there is not a true preoperative baseline. We incorporated this work into the development of our relative volume change equation. We found that statistically, this equation depicts arm volume changes over time most accurately after breast cancer surgery. It integrates the affected or A and unaffected or U arm volumes at time 1 preoperatively and time 2 time of follow-up. This is a percent change, and we talk to patients about their RBC and their percent change from baseline. Although we use the parameter as our measurement of choice, you could also integrate girth measures and convert to limb volume using a commercially available limb volume calculator. Data does not support using a 2 centimeter difference in circumference or a 200 milliliter difference between arms to diagnose lymphedema. These are not valid measures. They do not account for preoperative arm asymmetry or capture what's going on in the entire limb. This graph depicts or models a 200 milliliter increase in arm volume over time in terms of patients' baseline arm volume and the corresponding relative arm volume change. So in a patient with a larger arm volume at preoperative baseline, a change of 200 milliliters corresponds to a rather small relative arm volume change. whereas in a patient with a smaller arm volume at baseline, this 200 milliliter increase corresponds to a very high relative arm volume change of 13 and 14%. I would think about these two patients very differently in terms of their relative volume changes and in terms of how I might treat them. These are not valid measurements of using 200 milliliter difference or 2 centimeter difference between arms for diagnosis. My colleague Jean O'Toole wrote in 2013 that this lack of standardization regarding lymphedema diagnosis will continue to limit our knowledge in this field and moving forward. And fast forward to 2021, although we do have all these modes of measurement, the issue is that we have so many thresholds between these modes to diagnose lymphedema, and we see all of these still occurring in the research, including 200 milliliters and 2 centimeters. Many of these don't include baseline, which we know to be very important as well. So it is hard to compare research studies. It is hard to know that we are consistently diagnosing patients across facilities. And globally, we know that diagnostic criteria differ as well. I applaud the work of the Canadian Lymphedema Framework in that I know that from Dr. McNeely that these national breast cancer-related lymphedema guidelines are in the publication phase. So I'm very much looking forward to reviewing this. And I'm hopeful that we can have our organizations in the US come together to establish some national guidelines as well. We certainly have studies that can help us to do this. So we don't have a definition of early lymphedema. However, we know that we can only diagnose early if we are screening for it. There are many studies, quite a few studies, which have looked at early intervention, all of which have found a benefit of early intervention. However, these studies do have limitations. There are only 3 randomized controlled trials, only one of which examines compression versus no compression. And we know compression is the first-line treatment for lymphedema. There are varied diagnostic criteria and interventions, and only 6 of these studies use compression at all. So our aim of the current study on early intervention is to report results of early lymphedema diagnosis and intervention from within our screening program and make recommendations for future research. This is a retrospective chart review of 42 patients referred to the lymphedema therapist for edema management with a relative volume change of 5 to less than 10% and perimetry data at the beginning and end of the episode of care. A successful outcome is defined as RBC less than 10 at the end of the episode of care or at last follow-up. This is the demographics of this group, and you can see that in terms of nodal surgery, 61.9% of participants underwent node dissections. This is a relatively high-risk group for progression of lymphedema. In terms of CLT treatment, these patients underwent a median of 3 visits with the CLT. They had a median RBC of 7.89% at initial eval and 6.06% at end of CLT treatment. The median time of surgery to the first episode of low volume swelling or RBC of 5% was about 10.2 months. So within that first year postoperatively, and the median time since breast surgery to last follow-up was 52 months. This is a nice longitudinal view of this population. Interestingly, although they were referred for early lymphedema or early edema, 84.3% of patients had edema on clinical exam, noted by the CLT on initial eval. This depicts treatment received, and as you would hope, 100% of patients received education on lymphedema, 96% of patients received exercise of some type, 76.4% of patients received a compression sleeve. And then other treatments varied, such as a compression glove, night garment, chip bag, manual lymph drainage, manual therapy, or kinesiotape. At end of treatment, 92.9% of patients had an RBC of less than 10%, with only 3 progressing to an RBC of more than 10%. We really wanted to understand who these patients were. And in terms of progression to lymphedema, we wanted to understand how many we would have expected to progress, and then what was the effect of early intervention in this population. So we had some data on which to base this. We recently published, this was in June, we published data on 1,790 patients looking at subclinical lymphedema after treatment for breast cancer, risk of progression. So we looked at patients who were treated for breast cancer, stratified into node dissection or node biopsy, how many developed this low volume swelling, and how many progressed to lymphedema. And what we found is that those at highest risk of lymphedema, in fact, were most likely to progress after an episode of early swelling. So 39.2% of patients who had early swelling after lymph node dissection progressed to lymphedema, but only 11.5% progressed to lymphedema after node biopsy and developing early swelling. So it looks like the higher risk group is at much higher risk of progression to lymphedema after this low volume swelling. So we use these numbers to determine the number of patients we would project would progress in this study. So unfortunately, the number of patients with sentinel node biopsy were quite low, and we didn't want to draw conclusions based on such low numbers. However, in patients post-ALMD or node dissection, we projected that 10 or 39% would progress to lymphedema, but only 2 progressed at the end of treatment with an 80% relative reduction rate, and 7 progressed at the last follow-up, which was a 30% relative reduction rate. So for the entire cohort, this corresponded to a 16.7% relative reduction in lymphedema progression with early intervention. This is good news, but we wanted to understand better who these patients were and what happened after we finished seeing them. So this table depicts the 3 patients who had lymphedema or RVC of more than 10 at the end of CLT treatment. So lymphedema risk factors are highlighted in red. We can see the 1 patient with node biopsy who progressed. And again, these patients are at low risk of progression, but their risk is not negligible. So this patient had every risk factor for lymphedema and in fact did progress, but has been lost to follow-up post-COVID. We haven't been able to get her back in yet. The second patient, her RVC increased substantially during CDT from 8 to 23%. And I referred her back to her oncologist to look for a potential recurrence, which was not the case. And she was immediately referred to lymphatic surgery and will be undergoing lymphatic surgery. The third patient had an elevated body mass index, and she kept up with her compression after we saw her. And at last follow-up, she had resolved to 5% and has been doing really well. 8 patients progressed to lymphedema after CLT treatment at some point. Again, their lymphedema risk factors are highlighted in red, and many carried more risk factors than nodal surgery alone. Interestingly, the end of treatment to the time that the RVC popped up over 10 was about 10.7 months. So this highlights the need to follow these patients closely. Their RVC at last follow-up was a median of 13.18%. So all patients bar 1 had RVC that remained under 14%. Unfortunately, we have no symptoms data and we have no quality of life data. And I would be really curious to see whether or not patients felt that their symptoms were under control and if their quality of life was acceptable or hopefully good with their volume contained where it was. So we were able to see these patients for early swelling, put them back into routine screening, catch them quickly, see them again, and keep their volume low, under 14. So these patients were either stable, referred to lymphatic surgery, in current treatment for another flare, and 1 was lost to follow-up. So in conclusion, screening is standard of care. It is what we should be doing for patients, and this is how we will be able to intervene early. It appears from this data that those at high lymphedema risk may benefit most from this early intervention. Close follow-up is indicated, and popping these people back into the routine screening so that we can capture any progression and see them quickly. Patients who progressed to lymphedema after node biopsy carried at least another lymphedema risk factor. We were able to limit progression in terms of volume. I am not sure if we were able to limit progression of symptoms or contain quality of life to be acceptable or hopefully good for these patients. I would love that data. This is a balance in terms of over-treating, treatment is burdensome, versus under-treating, progression of lymphedema is burdensome. Clinical lymphedema needs to be treated with CDT. There are obviously limitations. This is a retrospective study with a small sample size without a control group, and I don't have that symptoms and quality of life data. We are in the process of establishing a pilot in preparation for a phase 3 trial using a control group without compression, integrating adherence and dose, seeing who benefits most in terms of risk stratification by lymph node surgery, and integrating volume, clinical exam, symptoms, and quality of life. This must be done in the context of a screening program, and we are well positioned to do this at MGH, and we look very much forward to establishing some of this data to determine the efficacy of early intervention. Thank you.
Hi, my name is Alphonse Taghian. I am a breast radiation oncologist and the director of the Lymphedema Research Program at Mass General Hospital in Boston. And I would like to thank the organizers of this conference for giving us the opportunity to present our work. So I will be talking about risk factors for breast cancer-related lymphedema. So as we all know, treatment of lymphedema is very challenging. So in order to improve the outcome, we should have two different approaches. One is screening to identify patients with early swelling and intervene at that time if possible. Two is identify risk factors to develop lymphedema. And in this situation, we can keep close eye on the patients and screen probably more often and intervene as early as possible. Those are the risk factors I'm going to talk about one by one and see what the impact on lymphedema. So the first one is the most important one is the axillary lymph node dissection. So here is a study from our group. We looked at 1,800 patients prospectively, followed from our screening program. All patients had a baseline measurements and follow-up with spirometer every 6 months. So we use the relative volume change, which is a formula which integrates the baseline measurements, and we defined lymphedema as an increase in relative volume change of 10% or more. So this cohort was divided into 4 groups for comparison: lymph node dissection, and central lymph node mapping, plus or minus regional lymph node radiation. So the risk of lymphedema at 5 years for patients who had lymph node dissection, plus or minus radiation, varied between 25 and 30%. And when we compare with sentinel lymph node, varied between 8 and 11%. This difference was highly significant. And it's almost universal in the literature, with very few exceptions, that lymph node dissection has a much higher risk than sentinel lymph node mapping to develop lymphedema. And one of the most important study is the meta-analysis from DeSapio, and they show that it's 20% versus 5%, and then we can go on and on with many other papers in the literature. So number 2 will be regional lymph node radiation. So here is a study also from our group, 1,500 patients prospectively followed. And the goal of this study is to compare the risk of lymphedema between different types of radiation. Radiation to breast alone, or radiation to breast plus regional lymph nodes, which included the supraclavicular lymph nodes, the axilla, and the internal mammary chain. The risk of lymphedema was 3% when we treat only the breast, and 21 to 22% when we add regional lymph nodes to that. And this graph illustrates this big difference, which is highly significant. So this was further broken down by the type of axillary surgery, sentinel lymph node here and lymph node dissection there. And as we see, when we add regional lymph node radiation after lymph node dissection is 25%, and if it was to sentinel lymph node, it will be around 7%. And we'll come into this in a few slides. When we did the multivariate analysis, regional lymph node radiation was significant risk factor among the other classic factors: lymph node dissection, BMI, and early swelling. Now, I want to go back to this study, but we will look at it from a different perspective. So we wanted to quantify the contribution from regional lymph node radiation vis-a-vis the contribution of axillary surgery in the risk of lymphedema, which means like which factor cause more risk, and how much is this risk. So we can see here that when patients had lymph node dissection, the risk of lymphedema was 25%. When we added radiation to that, and I mean regional lymph node radiation, we added 5%, became 30. Same thing with sentinel lymph node, it went up from 8 to 11%. The contribution of radiation to the risk of lymphedema was quite minimal. It varied between 3 and 5% compared to 25 and 8% without the regional lymph nodes radiation. So you could see also in the multivariate analysis comparing lymph node dissection plus regional lymph node radiation to lymph node dissection alone, the hazard ratio was 1.2, and the same for sentinel lymph node, it was 1.3. So there is no doubt that regional lymph node radiation increased the risk of lymphedema, but this was not significant here. So the impact of regional radiation to the risk of lymphedema is much smaller than the impact of axillary surgery. So a very interesting study from our colleagues from Chicago with Jonathan Strauss. They looked at 265 patients retrospectively, and they wanted to identify any specific volume in the axilla or the supraclav which received a dose of radiation, and find out which part of this area is the trigger which increased the risk of lymphedema from this radiation. So they found that this specific area here, they called it axillary lateral thoracic vessel juncture. And they looked at the dose of radiation here. If this dose was more than 38 gray, the risk of lymphedema increased significantly, and this was found in a multivariate analysis along BMI and lymph node dissection. And this will be actually very important if this study is validated, because we can easily control the dose to this area if it is safe, and in the same time we just like might improve lymphedema. But I have some issues with the study that they use the definition for lymphedema as 2 centimeter increase in circumference of the arm without really baseline before surgery. So it will be great if this study is validated. We looked at the timing to develop lymphedema according to the treatment received in this cohort of more than 2,100 patients. So you could see here, so that's the risk of developing lymphedema per 6 months. So with lymph node dissection alone, we can see a steep increase in the risk of lymphedema. It plateaus from 6 to 12 months and start in a very shallow way to just go down little by little until it reaches the 5 years. If we add regional lymph node radiation to that, this line will go in the same steepness, a little bit higher, and then will plateau between 18 and 24 months. So it takes more time from radiation to increase this risk, and then little by little this risk will go down at 5 years. Similar in a lower scale, the sentinel lymph node alone versus sentinel lymph node plus regional lymph node radiation, the risk is not really high, and then it plateaus, and then it also goes down. So from this slide we can see that the addition of risk to lymph node dissection from the radiation is quite smaller than the original risk from the lymph node dissection alone. So in conclusion, although regional lymph node radiation increases the risk of lymphedema, the main contribution to this risk is the extent of axillary surgery. And therefore, omission of axillary dissection, if possible, should be the key to use in a prevention strategy. What about BMI? So BMI is a universal factor known as a risk for lymphedema. So here is a study from our group, almost 800 patients, prospectively monitored with a parameter. And in the multivariate analysis, it shows that BMI, comparing more than 30 versus 25 to 30, or more than 30 versus less than 25, that the hazard ratio varied between 2.5 and 3.5, and this was highly significant. The model also showed that lymph node dissection and regional lymph node radiation was significant. Many other investigators found similar results. Now, regarding the weight fluctuation, so you would think that if the BMI is a risk factor for lymphedema, maybe reducing the weight should decrease the risk of lymphedema. But our data did not show that. On 1,100 patients, we followed their weight over time, over 5 years. We looked at patients who gained weight and patients who lost weight, and there was no significant difference in the risk of lymphedema. It's actually, Kathy Schmitz also found that weight loss did not affect the lymphedema risk outcomes using a home-based resistance exercise program and a weight loss program, or in combination of the two, compared to the control group. So this was a little bit of disappointment, but this actually came from two different groups. So what about chemotherapy? The association between chemotherapy and lymphedema is really weak and not well defined. So here we have some studies which found a significant association with lymphedema, and here are other studies which found exactly the opposite, that there is no impact on lymphedema. But there are some talks about the impact of taxanes-based chemotherapy on the risk of lymphedema. We in our group did not find that taxane was a risk, but we didn't have enough patients for this study. And I think we should keep this factor in our mind, that it's still not clear. What about cellulitis and seroma? Both are sort of like really well-known factors to increase the risk of lymphedema. Several authors found that cellulitis is a risk. We looked at 630 patients in our screening program, and we did a multivariate analysis, and we found that BMI, lymph node dissection, regional lymph node radiation, and cellulitis are a significant risk to develop lymphedema. It should be noted that cellulitis increases the risk of lymphedema, and lymphedema itself in its turn increases the risk of cellulitis, and then we go into a vicious circle. And some patients actually with lymphedema, when they develop several times cellulitis, they are put on antibiotics for life. What about subclinical lymphedema? So subclinical lymphedema is defined as an increase in the arm volume from baseline that does not qualify as clinical lymphedema. And clinical lymphedema means it's visible on a clinical exam, or there are symptoms reported. But subclinical lymphedema, you don't have these two factors, but you have a quantifiable increase in swelling, which is always less than 10%, and then we defined subclinical lymphedema to have a relative volume change varying between 5 and 10%. So our team sought to find the answer to the question, is subclinical lymphedema a risk factor to develop a full lymphedema? So we prospectively performed arm volume measurements on 1,800 patients, mostly with sentinel lymph node, and 75% and 25% had lymph node dissection. Overall, 25% of those patients, all comer, develop subclinical lymphedema, which means a relative volume change between 5 and 10%. So when we broke this down into two groups, the group with lymph node dissection and the group with sentinel lymph nodes. So what we found that in 430 patients with lymph node dissection, 39.7% developed subclinical lymphedema, and among them 39% progressed into full-blown lymphedema. So they moved from 5 to 10% into 10% or more. And then we had 1,359 patients with sentinel lymph node. 25% of them developed subclinical lymphedema, but only 10% from the sentinel node cohort progressed and developed a full-blown lymphedema, which means 10% or more. So this subclinical lymphedema is a great window to intervene with treatment and could be the subject of a phase 3 trial, but would not be able to identify subclinical lymphedema without screening. So in order to get the patient early, we should screen. So in conclusion, patients who experience subclinical lymphedema after axillary surgery are more likely to progress to BCRL. Patients with lymph node dissection are at a significantly higher risk of progression, and early intervention could be encouraged. So what about avoiding axillary lymph node dissection for patients with positive sentinel node? Will this reduce the risk of lymphedema? So it is sort of like for a long time and still in many places that surgeons perform lymph node dissection for patients with 1 or 2 positive sentinel nodes. So can we avoid that? So a group from the Netherlands tested this hypothesis and initiated a phase 3 trial. They called it AMAROS. And they included 1,425 patients with 1 to 2 positive sentinel node, and they were randomized to completion of lymph node dissection or doing just regional lymph node radiation without completion of lymph node dissection. The clinical outcome in terms of local failure, disease-free survival, and overall survival was actually similar, but the rate of lymphedema went down from 13 to 6%. And here is the methodology actually which came up with this number, because we think that 13% for lymph node dissection is quite low. In fact, in this trial, they defined lymphedema as a relative increase in arm circumference, and they measured the arm circumference at only 2 points. They did not use volumetric changes, like the 2 points were 15 centimeters above and below the elbow. So nevertheless, the message is loud and clear that avoiding lymph node dissection significantly reduces the risk of lymphedema. So we looked at our cohort of 1,800 patients, and we used a more accurate methodology as described before, and we found that if you do lymph node dissection, your risk of lymphedema will vary between 25 and 30%, but if you do sentinel lymph node and you avoid lymph node dissection and you substitute this lymph node dissection by regional lymph node radiation, your risk will go down into 10%, which is a tremendous benefit for the patient. So I wanted to talk very briefly about the question: does precautionary measures reduce the risk of lymphedema? So as you know, precautionary measures, we mean those guidelines which usually are discussed with the patient. No blood draws, no blood pressure readings in the side of the breast surgery, no infusion, no injection, and if you take a long flight, put a sleeve. So, and the goal of this is to avoid increase in the risk of lymphedema. At least that's what people thought at that time. So we wanted to look at this issue and find out whether this is based on a solid data or not. So we had 632 patients with 3,000 measurements and with 1,700 events, and those are the events here. And we looked at the risk of lymphedema. We did not find anything. And here in the univariate analysis, whether a blood draws, a 1 time or more, injection, blood pressure, and a flight, length of flight, long flights, a short flight, we didn't find any increase in the risk of lymphedema, only in cellulitis and trauma. And when we did the multivariate analysis, only BMI, lymph node dissection, regional lymph node radiation, and cellulitis showed that those are the risk of lymphedema. So here we found no significant association between precautionary measures with arm volume increase, and recommendation were supported with very weak, soft evidence. And this study generates evidence that brings reasonable doubt that those guidelines will bring any benefit. So in conclusion, how can we reduce the risk of breast cancer-related lymphedema? Screening program for early detection and early intervention, identifying high-risk patients, as we mentioned, for counseling and close observation, avoid lymph node dissection in patients with 1 to 2 positive sentinel node, and apply the AMARO study, and there is another study called Z11. And there is no definitive scientific evidence that precautionary measures increase the risk of lymphedema. So for future direction, I think we need to work together on having a universal definition and a measurement method for lymphedema, so we can have comparison between the different studies. And we need to find out if precautionary measures are needed. Phase 3 trial does early intervention, prevent progression, and as a minor thing, we need to individualize a tool to estimate the risk to develop lymphedema in individualized base, and the cost analysis for screening, which a couple of the studies have shown that it is much cheaper to the healthcare that you do screening than wait until you treat a patient. I would like to acknowledge my team, and as you see that it's a long list, and without my team, I would not be able to present any of the data, and I would like to thank you for your attention.